How's it going, guys? We have a medium difficulty question for biochemistry. 56-year-old man, 2-week history of increased thirst and urination, polydipsia, polyuria, and he's had change in his visual acuity during this time. Things are more blurry. Does not wear eyeglasses. He's lost 5 pounds during this time. BMI 36. What's most likely to see in his patient? So this is acute type 2 diabetes mellitus. You can get weight loss with acute type 2. I've seen it on NBMEs. And this combination of polyuria and polydipsia refers to the word diabetes in isolation. So diabetes insipidus and diabetes mellitus vignettes can sound very similar because of polyuria, polydipsia in both. But the change in visual acuity here, which we'll talk about, is specific for diabetes mellitus, okay, for both 1 and 2. But in this case, clearly it's type 2 with the high BMI, middle age. So let's just whip through the answers. What are we going to say? Choice A, decreased GFR is wrong. Now, if you've been following my content, you know I've inculcated the point that the first change in the kidney we see with diabetes is hyperfiltration, increased GFR. And the reason is because the high glucose crossing the basement membrane is going to pull water with it, and that's going to cause your polyuria. They really like that as the first change in the kidney. Now, of course, over time, you're going to get non-enzymatic glycosylation of the glomerular basement membrane, thickening of the GBM, loss of the size and charge barrier, and ultimately chronic kidney disease with a drop in GFR. But initially, it's hyperfiltration with a high GFR they like for DM. Choice A, wrong fucking answer. Choice B, decreased polyubiquitination is wrong. So ubiquitin is a molecule within the cytoplasm that is tagged to proteins to send them to the proteasome for breakdown. So in the catabolic state, we would have increased proteolysis. In the setting of type 2 diabetes mellitus, where we have insulin resistance, it's as though we have a deficiency of insulin. What does insulin normally do in terms of macromolecules? It's going to stimulate protein synthesis, stimulate fatty acid synthesis, stimulate glycogenesis with glycogen synthesis. So if we have a resistance to it, it's the opposite. So we'd have glycogen breakdown, okay, glycogenolysis. We'd have fatty acid breakdown, lipolysis, and we would have protein breakdown, proteolysis. So we would have increased polyubiquitination. Choice B, wrong fucking answer. Choice C, decreased pyruvate carboxylase activity is wrong. So don't confuse this enzyme with pyruvate dehydrogenase. Pyruvate dehydrogenase is going to send pyruvate into acetyl-CoA for the start of the TCA cycle in the fed state. Pyruvate carboxylase, in contrast, is a gluconeogenic enzyme that's active in the fasting state. It converts pyruvate into oxaloacetate in the TCA cycle, which then via PEP carboxykinase goes back up to phosphoenolpyruvate and then back up to glucose. So in the setting of insulin resistance, we're in the pseudo-fasting state, and we're going to have increased gluconeogenesis with increased pyruvate carboxylase activity. Choice C, wrong fucking answer. Choice D, increased aldose reductase activity, correct answer. This is why we have the visual blurring here. So there's 2 points for USMLE you have to know about aldose reductase. The first is, in the setting of diabetes mellitus, glucose enters the lens of the eye. Aldose reductase converts it into sorbitol. Sorbitol is a high osmotic pull, causes osmotic distortion of the lens, leading to visual blurring. It's a very important screening question for overweight patients who have changes in their vision, okay? So, or changes in their urination and drinking habits. In other words, you got a dude who comes in, he's been peeing a lot, you say, have you had changes in your vision? They say yes, right away you check their sugar levels. Okay, it's an important screening question. Now, the second point you got to know about aldose reductase is the galactose disorders in pediatrics. So you're going to have galactose via aldose reductase converts it into galactitol, which is the mechanism for cataracts and the galactose disorders. Obviously unrelated here, but I'm just making a point about it biochemically. So let's just whip through the final answer here. Increased glucokinase activity is wrong. So glucokinase is the hexokinase variant in the liver. Hexokinase ubiquitously in the glycolytic cycle, converting glucose into glucose 6-phosphate. But glucokinase in the liver has a higher Km less affinity for glucose, which makes sense because you want your peripheral tissues taking up your glucose ahead of the liver for energy utilization. But when glucose is high in the blood, then glucokinase can start to soak it up with its lesser affinity. So it has a higher KM. It also has a higher Vmax, greater saturation capacity for glucose, which makes sense because when glucose is high in the blood and insulin is high, which activates glucokinase, the liver is going to soak up the glucose, converting it into glycogen as a buffer. So in this case, because we have insulin resistance, it's as though we have a deficiency of insulin, so we're going to have a decrease in glucokinase activation. Choice E, wrong fucking answer.